Welcome to Let's Clear the Air, a podcast sponsored by the Allergy, Asthma, and Sinus Center, dedicated to educating listeners about allergies, asthma, and immunology.
This is Marcella Feathers, and welcome to a new episode of Let's Clear the Air, all things allergy, asthma, and immunology. I have the pleasure of being here with Dr. Phil Jones. Hello, Dr. Jones.
Hey, Marcella, it's great to be back.
Well, we are excited to have you. You always give us some interesting conversation. So let's just jump right into it while we're here. We are going to talk about today urticaria, but even more on the severe end of it, chronic urticaria. So why don't you explain just a little bit to our listeners what that is?
Well, Marcella, urticaria is a big word that, may not mean something to everyone. So I've learned over the years that people will describe urticaria as blisters. They will describe them as welts, knots, those kind of things, okay? But really, urticaria is a red various, they come in all kinds of shapes, from little tiny ones to hives that cover the entire abdomen, okay? But the thing that's universal among hives, they itch, okay? People will be, they'll have tears in their eyes. This itches, so you've got to help me. These are always tough ones. So it itches, it waxes and wanes, it will clear, usually in less than 24 hours, sometimes 48 hours. And that's a key, and they blanch. If we take them and pull them on the skin, they clear. That's called blanching. So that's what urticaria are. But the main things I notice about hives, they're very itchy, impair quality of life. Again, 2 patients who come into my office with tears in their eyes. I can't quit coughing is one of them, and I can't stop itching is the other one.
So I didn't realize that urticaria, a symptom would be cough.
It isn't cough, but those are just those 2 groups of patients that come to me with that same question and that look, you've got to help me. And, we all want to help, but you hate to be the last line. Most of them have been to 4 or 5 doctors, and they're like, you are the only one left to help me.
Yeah, I get that. Both of those would definitely just interfere with life, your everyday life.
Yes.
So with the chronic urticaria and the hives, aka hives,
yes,
I'm sure that folks are just wondering what's causing this and how do I fix this?
Yeah, so that's a tough part with chronic hives. So generally when I'm seeing a patient with hives, I'm asking them questions and I'm trying to put them in a category. Are you acute urticaria or are you chronic urticaria? Acute general is less than 6 weeks of hives. Chronic is more than 6 weeks of hives. And often with our chronic hive patients, I meet them and they've had them for years. Some of those are daily, some of those are intermittently, but they've had them clearly for more than 6 weeks. And everybody with chronic hives wants to know, what is causing this so I can stay away from it, okay? So there's always some education about what causes chronic urticaria. And we're learning more and more that in a lot of patients it's autoimmune disease. Now, not in the same, it's not like it's lupus or rheumatoid or Sjogren's that's causing their hives, but we form an antibody against a self-antigen, and that triggers our hives. And there's idiopathic urticaria, which is really doctor's talk for we don't know, okay? It sounds like we know what we're talking about, but we don't, and I explain that to them. There can be underlying illness, thyroid disease, liver disease, rare things like lymphoma, leukemia, those type things, but those are really rare things to present with urticaria. There is urticarial vasculitis. That's probably one of the more severe forms of urticarial rash that I see. Those patients, though, when I meet them, Marcella, they look sick. They're having fevers, night sweats, weight loss, joint pain. Wherever they get a hive, they either get dusking, which means I can see where it was for days, or even bruising. So that's a more significant type of urticarial rash, at least clinically in its implications. And then there's physical urticarias. Hot, cold, pressure, vibration makes me break out in hives. So my favorite patient is, I went to the emergency room and they told me to come see you because I'm allergic to something. So everybody thinks hives, even doctors think if you have hives, you have an allergy. But clearly there's many things that cause hives.
Wow, I have never heard of hives being caused by sound or, well, heat. I have heard of that, or
Hot, cold.
vibrations.
Yes,
Or,
I have met a poor little lawn mowing guy, and he would mow all day long on his mower, and he would show up with hives on his backside of his legs and his lower back and buttocks, just thick, thick, thick.
how do you rule out allergy as a factor or something?
So when you're going through hive patients, you always want to know, okay, when did it start? Were you sick at that time? Were you on new medications? Were you using over-the-counter medicines? We don't often ask about that, but NSAIDs are a common over-the-counter medication that trigger hives, or that can trigger hives. How long do they last? What's the distribution? Do they bruise? Do you have fevers, night sweats, weight loss? All these questions help figure out what it is, okay? For example, pressure urticaria. That likes the belt line or the bra strap, or, people nowadays, we all have those old plastic bags to carry in the groceries. Everywhere that bag sits on your arm as you carry it in, that's a band of hives. So the history is very, very, very helpful in finding out what's causing chronic urticaria, okay? So the hardest part of taking care of chronic urticaria is explaining to patients it's not an allergic urticaria. It's one of those other things we talked about, and you have to realize, boy, it's not as simple as avoiding milk or peanuts. It's really, hey, I'm hopeful this will run its course. They usually do. It may take a few years, but they usually run their course. And we just want to make sure that we've gone through that thorough history just to make sure there's not a trigger. But most of the time, it's a focus on treatment, not trigger.
Whereas, as we've always said, even with allergies, if you can find the trigger and eliminate the trigger, then that's ideal.
Ideal. But it's not always that easy.
No, not always that easy. It sounds like, especially for some of these patients,
Yes.
that it just pops up and they're like, I have no idea. Well, that's where they can come to you and go through, or even, I don't know that I want to say a primary care provider, but you can at least go through a history with them. And
Absolutely. Many people start either with an emergency room doctor or their primary care. They often see dermatology. Dermatology has things they can do, but they also often say, just go see the allergist. This is one of those things we share with dermatology, but I think dermatology is more than willing to say, hey, you guys take this and take care of it. And in the old days, we didn't have anything really to treat it with. The medicines had way too many side effects, Benadryl, hydroxyzine, and they made you sleepy. And even if they didn't make you sleepy, they made you mentally foggy and these type things. So it was just miserable, I can remember patients 20 years ago coming in, and I'd say, well, what are you taking for this? And they'd reach in their purse and pull out a bottle of Benadryl, liquid Benadryl. And I'd say, well, how much do you take a day? 1 or 2 bottles. And it was just an astronomical amounts of antihistamines. And now we have newer generation antihistamines like cetirizine and loratadine and fexofenadine. We can use them at much higher doses. We use them up to a maximum of 4 a day. And we try to avoid hydroxyzine and doxepin and those type things. We try to avoid steroids because all they do, even if they work, they clear it and it comes right back. And then there are injectable medicines, these things called biologics that we use and they've just been a miracle drug for our chronic hive patients. There's now available are Xolair and Dupixent. There will be others, and there will even be oral agents you can take specifically for hives, new oral agents. So these patients went from very miserable, no hope, horrible quality of life to now doing really, really well, okay? In fact, they do so well on those biologics, when I start talking to them about spacing them out or stopping them, they just look at me like, no, I'm never stopping it, because they don't want to go back to those hives that they vividly remember.
Well, that's excellent, though, that we have those options available now.
We're very thankful for those.
Yeah, because as you said, it's difficult to see patients in that state, so being able to offer something is encouraging.
Absolutely.
Well, let's move into something that you brought to my attention earlier, and that's Mast Cell Activation Syndrome. And that is linked to allergies, but misleadingly so, I guess, is the best way to...
They certainly end up in the allergy office, okay? So mast cells, they're kind of the allergist nemesis, right? every disease we take care of, there's a mast cell in some form or fashion involved. And they're in multiple organ systems throughout the body. So they lead.
Let me interrupt you for just a second, but can you explain to us, give us a brief biological lesson on what a mast cell is?
Yeah, so mast cell have a number of mediators that they release, and one of those is histamine, but there's other inflammatory markers that they release. And so mast cells are very important in hives. They're very important in angioedema. They're very important in anaphylaxis. And so as time has evolved, we realize there are people who have mast cell disorders. There's clonal mast cell disorders, and I always tell patients it can be on a huge spectrum of mast cell disorders, from mast cell activation to all the way to mastocytosis. And so as with many diseases, there's a lot of good information out there, and there's some not so good information. So in the lay literature right now is a lot of discussion of Ehlers-Danlos syndrome and a connection to mast cell disorder. So fortunately, we had the American Academy of Allergy, Asthma, and Immunology said, look, guys, we need to have this is what it looks like. This is how we test for it. This is how we treat it, okay? And that work group committee said the definition of that disorder is having symptoms consistent with a mast cell, okay, or a mast cell mediator. So that would be typically urticaria, angioedema, anaphylaxis. Additionally, they said you had to have elevated markers of mast cells. And there's one we check in the blood called tryptase, and there are 3 or 4 that we check in the urine with a 24-hour urine. So there's a test. It's nice to have a test that you can say, hey, it's elevated or it's not,
Sure.
okay? If it's normal at baseline, we can repeat it during an episode. If it's elevated, that supports the diagnosis. If it's unchanged, it's not really consistent with that diagnosis. And then we have treatment, and that's basically a medicine that blocks anything a mast cell could release. We want to have a medicine that blocks it. And so that's the definition. But if you get online and inquire about mast cell disorders, you'll find forgetfulness and IBS type symptoms, but not urticaria, angioedema, anaphylaxis. So really, if you don't have those classic symptoms, either angioedema, urticaria, anaphylaxis, you just have other symptoms that could be mast cell mediated, but to be a mast cell disorder, you have to have urticaria, angioedema, anaphylaxis.
Okay, so definitely look for those 3
Yes,
symptoms.
absolutely.
And as always, we want patients to come to us and come to the experts, obviously, for this type of diagnosis, and not rely on cousins or friends, or as you referenced before, just online group chats for diagnosis
and there's so much
and
of that.
treatment.
I think that's the future. My friend saw this, and those kind of things. So.
Whereas you have been through quite significant learning, universities and degrees, and your years of experience.
Yes.
Whereas maybe the friend just read something.
Absolutely. But again, we talked about this earlier. If you disprove or don't agree, or you're like, no, you don't have it, then they're back online. He doesn't know anything about mast cells. Don't go there. So it's a vicious cycle.
All right, so let's say that there is a patient who thinks they have mast cell syndrome. They come in, they don't have those 3 symptoms, or they're not presenting those, and the blood work came back negative. What is it? Is it just a reference back to primary care, or is it an immune situation? Or
I think Marcella, you'd get a lot of different answers to that question. But again, I visual this when I see this patient, I can tell they're suffering. They have something. They want help, and they want to try to figure this out, even if they already have a preconceived idea of what they have. So I explain to them what I just told you. This is the symptoms. This is the diagnostic testing, whether it's a tryptase or 24-hour urine for mast cell metabolites, and then you have to respond to treatment, okay? So I'd say, you know what, I have to help them work through this,
Sure.
okay? I have to bring them to the point where they realize, I don't have this, okay? So part of that might be saying, I don't think it is, but let's do a tryptase. Let's do this 24-hour urine, and when they see that comes back negative or normal, they realize that, okay, then you're starting to change their perception of what they have. And then that last criteria is you have to respond to treatment. So I might say, you know what, I don't think it is, but let's try this for 2 weeks and see if it makes a difference. So then I have no elevated markers, you didn't respond to treatment, and then they're like, okay, what could it be? And then I can help them work through that. And if it's chronic GI symptoms, well, let's recruit the gastroenterologist. If it's chronic joint pain, let's recruit the rheumatologist, the right people to take care of those kind of things. And again, mast cells are throughout the body, so they can present with many symptoms. But the key is they really have to present with those symptoms and urticaria, angioedema, and anaphylaxis.
All right. Well, we appreciate you helping us clear that up a little bit. And if you think this is a condition you have and you've been told to come to the allergist, please come see us. We are certainly open and willing to help you find whatever is happening.
Absolutely. Patients will often say, Marcella, I'm sorry, I didn't mean to waste your time. There's never, ever, ever been a patient that wasted my time. Whether we found the answer and there was an allergic etiology to it, or whether we realized it was another problem that another subspecialist needed to take care of, we helped them work through it.
Yeah.
And that's all that matters.
That's what we're here for.
Yep.
All right. Thank you so much, Dr.
Thank you.
Jones. And that's it for this episode of Let's Clear the Air.
We hope you've enjoyed this episode of Let's Clear the Air. Please consider following this podcast, and remember, if you want helpful and accurate information about allergies and asthma, our allergy experts are here to clear the air.